Good morning. Good morning, everyone, and thank you for joining us this morning for Winship Grand Rounds. If you are an Emory University or healthcare employee and would like to receive CME credit hour for attending today, the login information can be found in the chat feature on the bottom of your screen. And if you have any issues with this webinar or the CME login, please send Julie Hawkins an email or drop a note via the chat feature. This morning, we are pleased to welcome a very dear colleague, Dr. Jolinta Lin. Dr. Lin is Assistant Professor in the Department of Radiation Oncology here at Emory University School of Medicine. She's a board-certified radiation oncologist, and she practices general radiation oncology and specializes in the treatment of breast and gastrointestinal cancers. She treats patients at Winship Cancer Institute and the Laughlin Radiation Oncology Center at GRADY Memorial Hospital. Dr. Lin graduated from MIT with Bachelor's of Science in Biology and completed medical school at the University of Maryland School of Medicine. She subsequently completed a medical internship at Greater Baltimore Medical Center and a radiation oncology residency at the University of Maryland Medical Center. Dr. Lin's research interests include understanding mechanisms of toxicity from radiation therapy, identifying potential pathways to decrease side effects, and improving patient quality of life issues. While in residency, she helped initiate a clinical trial that studied the effects of probiotics in patients undergoing prostate cancer treatment. Please join me in warmly welcoming Dr. Lin.
Well, thank you, Dr. Alashay, for the kind introduction, and thank you to the organizers for inviting me to participate in Winship's Grand Rounds. Today, I'm pleased to talk about anal cancer and the dear topic of mine, HIV. So the agenda is to go over some background as well as some current treatment for anal cancer, radiation therapy techniques, including toxicities, as well as outcomes affecting HIV-infected patients, and some newer trials that are ongoing or recently reported. So anal cancer is a relatively rare cancer. It's only about 0.5% of all new cancer cases in the US and represents about 2% of all GI cancers. The survival is relatively good, 5-year overall relative survival of 69%, with the median age of diagnosis around 63 in the general population. In 2021, there are going to be an estimated new cases, 9,000, and for estimated deaths, about 1,400. In the general population, anal cancer is slightly more common in women than men, and the rate of new anal cancer cases is about 2 per 100,000 men and women per year, based on 2014 to 2018 cases. So anal cancer is relatively rare, as I mentioned. However, the incidence is continuing to increase. The rates of new anal cancer cases have been rising, averaging 2.1% each year over 2009 to 2018. And the death rates have also been rising, averaging 3.2% over that same time period. Looking at it by year, we can see that there's a huge jump in anal cancer cases in 2000s in the United States, and that's also reflected in the right side in Georgia. We know there are several risk factors associated with anal cancer, including HPV, particularly HPV-16 anal genital warts, contributing about to 86 to 97% of anal cancers are attributed to HPV infection, and immunosuppression, such as solid organ transplantation and HIV, high-grade intraepithelial lesions, history of receptive anal intercourse, high number of lifetime sexual partners, history of STDs, history of cervical, vaginal, or vulvar cancer, and smoking. So the anal canal's anatomy is relatively straightforward. The length is about 3 to 5 centimeters, and the superior border is the anal rectal ring, right here. The anal verge is the inferior ring, and there's a dentate line that is the transition zone between the columnar mucosa and the non-keratinizing squamous epithelium. Anal margins often Anal margin cancers are often lumped together with anal canal cancers because they're often treated the same way if the lesion can't be removed completely with surgical excision. And the anal margin is defined as the 5-centimeter radius outside of the anal verge, but not including the anal verge. If the lesion is over 5 centimeters away from that anal verge area, then it's considered a skin cancer, and that can be treated very differently than what we'll be talking about. For anal cancer, there are several regional lymph node basins that we will often look for in terms of treatment, as well as during diagnosis. And that includes the mesorectal region, the inguinals, superior rectal external, and internal iliacs. Regarding histopathology, the vast majority are squamous cell carcinomas, and again, most of those express HPV. The other subtypes are relatively rarer, and as you can see on this table, the overall survival for same stage as squams is much lower. For the TNM staging, the T stage is based off of size primarily, and that has stayed the same in the current 8th edition as compared to the 7th edition. The change that has happened in the N staging is based off of, again, the nodal regions that we had mentioned before. It's a little bit simpler now, as if there's a node that's in those regions, then it's considered N1, as opposed to before where they had to distinguish by N1, 2, or 3 based off of which side, if it was bilateral or if it was both inguinal and perirectal. So the reason why the TNM staging is important is because we can see a clear differentiation between the multiple groups, and particularly in overall survival and disease-free survival. And as with many other cancers, the more advanced cancers tend to do worse. Now I would like to talk more about HIV and its relationship to anal cancer. So this is a diagram from the CDC mapping out the regions of HIV diagnosis in 2018. And you can see that the South contributes for the vast majority of the patients that were having new diagnoses. And actually is more than the combination of the other 3 regions combined. And if you look at the blue in the South, the vast majority are diagnosed in the urban areas. When we look specifically at Georgia in 2019, Georgia was the 4th in most cases of new HIV diagnoses, only behind Florida, California, and Texas. There were 2,439 new cases, and that consisted of the 2nd highest rate of HIV diagnosis per 100,000 people. And in 2016, the CDC called out Atlanta as the 4th among metropolitan areas of residence for the most diagnosis of HIV infection. And that impacts us significantly here as we are comfortably located in the Atlanta metro area. So with HIV, we will see multiple cancers that often are associated. So there are AIDS-defining cancers and non-AIDS defining cancers. The 3 types of AIDS-defining cancers include Kaposi sarcoma, non-Hodgkin's lymphoma, and cervical cancer. The non-AIDS defining cancers are listed below, and in general, these non-AIDS defining cancers have a 2 to 3-fold higher incidence in HIV-infected population. What I hope to demonstrate to you now is that that is in those cancers, but in HIV and anal cancers, that relationship is much higher. And that's partly because of the relationship between HPV and anal cancer. So HIV-infected patients are more likely to be co-infected with HPV, and that's about 2 to 6-fold higher, possibly because of risk factors such as sexual behavior. And in the HIV-infected population, men actually have an increased relative risk of developing anal cancer, 37.9 versus 6.8 when compared to women. And it is thought that increased risk with sexual practices such as men who have sex with men, also known as MSM, are associated with a higher incidence of anal cancer. And HIV-infected MSM have double the rate of anal cancer compared to HIV-uninfected MSM. And that can range anywhere from 70 to 100 per 100,000 versus the 35 per 100,000 in HIV-uninfected MSM. HPV infection persists in HIV-infected patients for longer compared to immunocompetent patients. They're thought that HIV-infected patients are 7 times more likely to have persistent HPV infection, and the immunosuppression in the HIV-infected patients could prevent that HPV clearance that is typically seen in immunocompetent patients. Thus, that may lead to a higher risk of developing anal cancer. And with the advances with modern antiretroviral therapy, the survival of HIV-infected patients has increased overall, leaving more time for possible HPV infection as well as anal cancer development. So the prevalence of anal HPV infection in HIV-infected men is very high, estimated about 86% or more. And the only published prospective study that looks at the incidence of anal HPV-16 and HIV-infected MSM was 92%. And that had a clearance of about 12.2% per year. So not very high, and the mean retention was about 36 months. This is a study that was published in 2012, looking at the different groups of anal cancer incidence divided by HIV infection as well as by sex and calendar period. And you can see that general increase in incidence for all groups, but in particular in blue, at the top, the HIV-infected MSMs have a particularly high incidence of anal cancer. And if you look at all the different HIV subtypes in terms of HIV-infected men or women or other HIV-infected men, then those are much higher than the general population listed below. And low CD4 count is considered a risk factor for increased incidence of anal intraepithelial neoplasia, AIN, or anal cancer. So when we look at the incidence of anal cancer, particularly in HIV men and in HIV MSMs, compared to other common types of cancers, it's actually pretty dramatic. And the estimates of anal cancer, again, for HIV-infected MSMs are the highest of the group, ranging from 77 to 137. And one trial actually estimates that 1 in 10 HIV-infected men or MSMs will get anal cancer over their lifetime, making this cancer a very profound one that we need to know how to treat and diagnose. So the definitive treatment for anal cancer is relatively the same compared to the 1980s. So prior to the 1970s, the major surgery, or major treatment was a pretty significant surgery, an abdominal perineal resection. And that was considered a standard of treatment where the anus and the rectum were removed and the permanent colostomy bag would be placed. The 5-year overall survivals ranged from 20 to 78%. But at Wayne State, they started using a different treatment paradigm, including chemotherapy and radiation. And this was led by Dr. NIGRO, where he used 5-FU and mitomycin, as well as 30 gray radiation, which is a little bit lower than what we use these days, as neoadjuvant treatment before an APR. So his original protocol actually had required the patients to undergo an APR after chemotherapy and radiation. But they saw that after operating on 6 patients, 5 of them actually had a PCR. And so they amended their protocol to include that the APR was only required if they had a positive post-treatment biopsy. So among the initial 12 patients that they looked at with APR after chemotherapy and radiation, 7 out of the 12, 58%, had no residual tumor. So they added more patients onto this non-operative approach, and with a total of 45 patients, 89% of them had no residual disease after chemotherapy and radiation. And among the 7 patients who had residual disease, they later passed of their distant disease. And if you look at their table, the ones with residual disease had much higher median size of 5 centimeters compared to the ones that had a past CR. So the evidence for chemotherapy and radiation is pretty strong. There are 5 randomized controlled trials looking at chemotherapy and radiation and which one is better. And you can see the pretty consistent group that they looked at was chemotherapy consisting of 5-FU and mitomycin. And I'm really only going to focus on the last one, ACTII, because spoiler alert, there hasn't been a lot of changes in the definitive setting yet. So the ACTII is the largest anal cancer study conducted in 940 patients. So this was actually a randomized phase 3 2x2 factorial study comparing 4 arms. It included 2 arms that had maintenance 5-FU cisplatin after the chemotherapy and radiation. They did use non-conformal parallel opposed fields for their radiation, which even the authors later comment that this was crude by in technical standards by what we do these days. And an important fact is for us is that they excluded HIV-infected patients. So the primary endpoint was complete response at 26 weeks, acute toxicities, and progression-free survival for maintenance. And you can see in the first line of the table, the complete response was very good, 90% in both groups. And when they looked at toxicities, about 20% required a radiation treatment break or reduced dose for the chemotherapy. They did have pretty significant toxicities. So 26% of the patients in the 5-FU mitomycin arm had grade 3 to 4 hematologic toxicities, and in the cisplatin arm, 16%. There was not a statistically significant difference in the non-hematologic toxicities, but again, you can see it's pretty high, grade 3, 4, 62, 68%. Regarding their progression-free survival, they didn't actually see any differences between the 4 arms, and so they advocate that no maintenance therapy is needed after initial chemotherapy and radiation. And they actually also advocate that mitomycin 5-FU has similar efficacy and toxicity with fewer chemo cycles of chemo, fewer non-chemo drugs needed, less time in the chemo suites, less costly, and no risk of neuropathy with the mitomycin compared to cisplatin. So this solidified the definitive treatment for immunocompetent patients with chemotherapy and radiation consisting of 5-FU and mitomycin, giving us a complete response of 90% and a colostomy-free survival of 74%. There was no benefit for maintenance chemotherapy, and the results for T1, T2 cancers, the small cancers, were excellent. The 3-year progression-free survival is 81%. However, they too noticed that the T3, T4, or patients with node-positive disease fared poorly. 3-year progression-free survival of 63%. So now I'm going to move on to talking a little bit about the radiation therapy and toxicities that we see when giving this treatment. As I had mentioned before, the ACTII study used parallel opposed beams, which can be seen similarly to the top panel, where you can see radiation dose is going through the entire genitalia, and even though the target is right here in the anus. That leads to increased toxicity all in the anterior portion and skin folds, as well as in their posterior bottom, whereas the IMRT, which I'll talk about in just a little bit, is much more conformal. So it's essentially treating areas that we would like to treat with high dose radiation. So for the radiation oncologists, this study was sort of a defining moment of in terms of radiation techniques, because the RTOG 0529 was a study that has now allowed for IMRT to be standardly used for anal cancer treatment. So this was a phase 2 study using dose-painted intensity modulated radiation therapy, also known as IMRT, in combination with 5-FU mitomycin to see if it could reduce acute toxicity and treatment for anal cancer. Their primary endpoint was looking to see if IMRT could reduce the grade 2 acute GI and GU toxicity by 15% compared to the historic toxicity rates of 9811, where they used 3D techniques. There were 52 evaluable patients. They used early stage cancer patients, T2 or above, to more locally advanced patients, T3, and allowing for up to N3 anal cancer. And all those patients received IMRT, 5-FU, mitomycin, and they did allow for HIV positive patients, but they had to have high enough CD4 counts where they did not have AIDS syndrome. They did not actually meet their primary endpoint. So the acute GI toxicities for grade 2 were similar, 77% for both for the IMRT group. And when they looked at secondary endpoints, they saw that they did have reduction in several other toxicities, including grade 2 hematologic toxicities, so 73% versus 85. And then in grade 3 as well, in grade 3 GI toxicity, so 21%. The dermatologic toxicity was significantly less, 23% compared to almost 49% in 9811. And the treatment interruptions due to toxicities was less frequent with IMRT, and that was a median treatment time of 43 days versus 49. And this again introduced IMRT as the standard treatment for anal cancer in immunocompetent patients because it decreased the toxicities, which are pretty significant. I will spare you of any pictures from toxicities, but I can assure you that when we do see grade 3 toxicities, it can be pretty dramatic, particularly in the skin. Not much has changed in terms of CTCAE grading from when they were doing the study for 9811 to now for this version 5 that we see. But we can see that, again, grade 3 is including moist desquamation in areas other than skin folds and creases, and bleeding can be induced by minor trauma or abrasion. The other side effects that they often look at is for diarrhea. If grade 3 is increased over 7 stools per day, requiring hospitalization. And of course, febrile neutropenia can be very concerning in these patients when they have significant either pancytopenia or fevers. So one thing that is starting to be a little bit more noticed is proton therapy. And proton therapy is a treatment modality that has limited exit dose when delivering radiation. Therefore, it has the potential to spare bone marrow, small bowel, bladder, femoral heads, and external genitalia. So there have been a couple registry studies who have treated patients with proton therapy, including a very sophisticated pencil beam scanning technique. And they did see that when they did a comparison plan for IMRT, they had lower doses of low dose radiation to, again, the small bowel, the bone marrow, genitalia, femoral heads, and bladder. So this is the IMRT plan where you can see that the red is the high dose regions, but the dark blue is the low dose regions. And you see that it's kind of spreads throughout the body despite having that focused radiation in the areas that we would like to target. The pencil beam scanning only has some low dose radiation going through as opposed to the entire body that has some low dose radiation that must have either entrance or exit dose. And when they looked specifically at the different organs, they again saw that the low dose especially seemed to have a benefit. Now we'll have to see if it is clinically meaningful, but they did say that this is at least clinically feasible to deliver proton radiation therapy, and we do see some patients getting treated with this. This is another dosimetric study that again demonstrates that there is lower exposure to low dose radiation with proton therapy compared to IMRT. And now I'd like to move on to talking about HIV-infected patients and what their outcomes are, as well as toxicities. So anal cancer patients with HIV were unfortunately excluded from the vast majority of clinical trials that have defined the treatment paradigms for anal cancer. Or if they did allow for HIV patients, they must have a high CD4 count to be able to participate. In addition, almost all of the studies that have been looking specifically at HIV-infected anal cancer patients have been retrospective. So the majority of the studies do show that HIV-infected patients tend to have higher grade 3 skin and hematologic toxicities compared to HIV-uninfected patients. And they often receive lower doses of chemotherapy and radiation compared to the HIV-uninfected counterparts because of toxicities. In addition, low pre-treatment and post-treatment CD4 counts have been associated with increased acute hematologic toxicities, hospitalizations, and tumor recurrence. This is an older study, but it's probably one of the first ones to really highlight the difference in outcomes and toxicities between HIV-infected versus uninfected. So this was published in the JCO in 2008. It was a retrospective analysis of a multicentric cohort comparison of 40 HIV-infected patients on antiretrovirals compared to 81 HIV-uninfected patients. All of them either received radiation or chemotherapy and radiation. And what they noticed was that the HIV-infected patients were younger, mean age of 48 compared to 62. They were mostly male, 93% versus 25%. tended to have early stage and also large cell histology for squamous cell. So differences in outcomes between HIV infected versus HIV uninfected are they had lower risk, for the overall survival was similar, so 61% versus 65%. And that could be attributed to, we still have APR as a salvage treatment if the recurrence is caught early enough. And they did note that there was a lower 5-year local control, 38% in HIV infected patients compared to a very high 87% in HIV uninfected patients. They did see worse toxicities in HIV infected patients, including 35% grade 3 to 4. And remember, grade 3 is considered severe, grade 4 is considered life-threatening. And they also had 33% grade 3 to 4 hematologic toxicities compared to 12%. And they did note for hematologic toxicities, about 50% of those the HIV population actually attributes about 50% of that toxicity in general. So the relapse-free survival in HIV positive patients was associated with radiation dose as well as severe acute skin toxicity. So they concluded that the long-term local control and acute toxicity represent major clinical challenges in the HIV infected patients. And even though it is feasible to deliver 5-FU-based chemotherapy and radiation and get a similar response initially with overall survival, we do need some improved treatment because the local control really is not very good. When they, when this study is a VA database study that looked at 142 HIV-infected male veterans who were treated within the VA system from 2000 to 2015. And they saw a dramatic dip in after treatment, and as well as a sustained dip in their CD4 count that never quite actually reaches back to baseline. So they saw that when they looked specifically at the CD4 counts in recurrence, that each 100 cells per millimeter cubed decrease in the CD4 post-treatment CD4 count, that actually increased the risk of recurrence by 54%. They also note that the decreased CD4 count after chemoradiation therapy was associated with increased acute toxicity, tumor recurrence, and prolonged suppression of CD4 counts. And that prolonged suppression of CD4 counts could be observed even 1 year post-treatment, exposing patients to potentially cancer recurrence or opportunistic infections. This group from Wayne State also looked at a retrospective population that was treated, 45 patients, and they also saw that the patients were less likely to receive full dose chemotherapy and radiation compared to their HIV unaffected counterparts. So the chemotherapy dose reduction happened in about 54% of the HIV infected patients compared to 12% of the HIV uninfected. And similar to the last studies was that the radiation was often interrupted, and that happened in 58% of the HIV infected as opposed to 42% in HIV uninfected. They did see similar overall survival and local control. And when we looked at our own HIV infected population at GRADY and Emory, we saw that we also did see that patients who did not have a full chemotherapy course tended to have worse progression-free survival at 12 months compared to those who had full dose chemotherapy. Similarly, with radiation, if they had a protracted course of radiation greater than 50 days, they did seem to have a worse 12-month progression-free survival compared to those that were able to complete their radiation without as many treatment interruptions. We're in the process of preparing this for manuscript form, but we also did look at our CD4 counts. However, we did not see a correlation with overall survival, cancer-related events such as local recurrence, distant metastases, or event-free survival with the CD4 counts. However, we do see that same sort of drop in our CD4 counts from baseline to 3 months post, as well as a lower 1 year post-treatment CD4 count. One study also reported meta-analysis that looked at 40 patients that included HIV-infected anal cancer patients treated with chemotherapy and radiation. And they saw worse disease-free survival, overall survival, and higher grade 3 to 4 toxicities. This was a big national cancer database study that looked at a variety of cancers among patients with HIV as well as patients without HIV. And when they looked specifically at anal cancer, HIV was associated with a substantially earlier stage of diagnosis. That potentially represents an example of where healthcare was directing their care and focusing them on HIV-infected patients and possibly screening procedures that were helping HIV patients, including MSMs. However, they saw that the stage-adjusted mortality for HIV-infected patients were higher than compared to their HIV-uninfected patients. And they saw that mortality after an anal cancer diagnosis was about 34% higher than in the HIV-infected patients compared to HIV-uninfected, even if they were at the same stage of diagnosis. So that brings us to the point of screening. Unfortunately, there's no formal national or international guidelines that exist for routine screening of anal cancer for HIV-infected patients. And this is a review article from Dr. Wells and Bruner that show that there are no randomized control studies that support this yet. However, there are a lot of different guidelines that providers can use to try to catch these anal cancers a little bit earlier. Thus far, anal PAPs have been improved with liquid-based tests, increasing that sensitivity up to 98% and specificity up to 96%. And if there's an abnormal PEP, that can lead to a high-resolution anoscopy, which can then visualize and possibly biopsy the lesion for histologic confirmation. So let me move on to some newer studies. So as I had mentioned, proton therapy is now a little bit more available than it was a couple years ago, but it hasn't been widely used in anal cancer yet. However, this study did demonstrate that it is a feasible thing to do in patients with chemotherapy or patients with anal cancer. And this was a pilot feasibility study that was done at MGH and UPenn, looking at that pencil beam scanning proton therapy with 5-FU mitomycin for T1 to 4 and 0 to 3 disease. So essentially anyone without metastatic disease. And their primary objective was to determine feasibility of proton therapy with concurrent 5-FU mitomycin, defined as grade 3 dermatologic toxicity less than 48%, which was the reported toxicity rate in that older study, RTOG 9811, where they used older techniques. So secondary objectives included overall grade 3 toxicity, as well as clinical complete response rate and disease outcomes. They too excluded patients with AIDS or other immunocompromised status. So among the 25 patients, 23 were able to complete their proton therapy as planned, and 40% required toxicity-related breaks, including one patient who actually had a grade 5 toxicity. That later was deemed not to be related to the treatment itself, but they did have to report that grade 5 toxicity. So the clinical response rate was very good, 88%, and that's similar to things that we have seen in the past. And so they also saw that the dermatologic toxicity was much less in the current study, 24% versus that 49%. And so they deemed that this is a feasible thing to do with proton therapy, and they are undergoing a phase 2 study with proton therapy as underway. Now, for second line treatment, there have been some developments. Immunotherapy is now something that we hear a lot about in the news, and there was a phase 2 study of nivolumab in patients that had been heavily treated for unresectable metastatic anal cancer, and that included 37 patients who were given nivo every 2 weeks, and all patients had to have previous treatment for advanced disease. Their median number of courses was 2 prior to the enrollment, And 32 of those patients did receive platinum-based therapy for metastatic disease prior to enrolling on the study. And the majority of the patients had received radiation to their primary tumor. They did include 2 patients with history of HIV infection. And their primary endpoint was looking at response rate according to RECIST category. They had 9 responses, 2 complete responses, and 7 partial responses. Of note, one of the HIV positive patients did have a partial response. And so at the time of data cutoff, they saw that 65% of the patients who received treatment had progression while taking Nivo and had a median progression-free survival of 44.1 months and a 6-month progression-free survival of 38% and a median overall survival of 11.5 months. They did include their toxicities, and they did not have any very serious adverse events reported. They conclude also that the Nivo is well tolerated and effective as a monotherapy for patients with metastatic anal cancer. So they also note that this was the first study that included immune checkpoint inhibitors for HIV positive patients who are at risk for developing squamous cell carcinoma of the anal canal. This was a recently reported abstract for the Keynote 158 phase 2 study, which includes a variety of cancers treated with pembrolizumab. And when they look specifically at squamous cell carcinomas of the anal canal, they did see that 5 patients had complete response and 8 had partial response. So they did see some anti-tumor activity and manageable toxicities in patients that were also heavily treated for previous anal cell or anal canal cancers. This is a study that is open but recently closed to accrual or about to close to accrual. It's an ECOG-ACRIN study that's looking at combined modality therapy, including chemotherapy and radiation, and following that with either adjuvant nivolumab or observation. So the primary endpoint is to see whether Nivo, after chemotherapy and radiation, can improve disease-free survival in high-risk patients, and that includes patients with nodal disease or large T3 or higher disease. They do allow for HIV-positive patients to join, but they must have a CD4 count of over 200, a serum viral load of less than 200 copies, and other requirements that they'll list in their protocol. They have several secondary endpoints as well. And we just received an email a couple of weeks ago saying that this study will be closed to accrual starting August 24th, so in a couple of days. We did open this study at Emory, and Dr. Alashay was the site PI for this study, and we were happy to have patients participate in that study. Another ongoing ECOG-ACRIN study is known as the DECREASE trial. This is taking early stage anal cancer patients, so patients with T1 to 2 and 0 anal cancers that are less than 4 centimeters to see if we can de-escalate their treatment. And so they have changes in their chemotherapy and radiation arms. And so the radiation arm the radiation and the mitomycin are lower in their experimental arm B, so the de-intensified arm. So instead of our typical 2 courses of mitomycin, they're only giving 1 dose of mitomycin, and that will be at 10 milligrams per meter squared. And the radiation dose will also be less, depending on if it's whether a T1 versus a T2. They have primary endpoints of disease control, as well as local regional failure, distant metastases, and treatment-related death. They also do allow for HIV positive patients, but they must have a CD4 count of over 200 and confirm no lymph node involvement by central review of imaging. This study is actively accruing, but it is not currently open at Emory. Now, trying to take a step back at even earlier stage cancers, there's an ongoing AMC 092 study that's looking at patients with what we call a SISCA, superficially invasive squamous cell carcinoma. So this is a phase 2 single-arm study looking to see if conventional surgery to remove the cancer is sufficient. And so it is planning to enroll 56 patients nationwide and looking to see if there are treatment failures at 2 years and if there are the number of incident SISCA or anal squamous cancers at sites other than that index SISCA. So this is ongoing, and this is also open at GRADY, and Dr. Flowers is the site PI for this study. There's a huge study that's also looking at screening and looking to see if more aggressive ablative therapy for high-grade squamous intraepithelial lesions is helpful in patients with HIV infection. And so this is a big phase 3 study that's looking to see a topical ablative therapy with active monitoring is going to be any different than patients who just undergo surveillance. So the primary objective is to see whether treating those patients with HSIL is effective in reducing the incidence of anal cancer in HIV-infected men and women. So these patients have not yet been diagnosed with anal cancer, but they're trying to see if this more aggressive screening and treatment could be helpful. Secondary objectives include determining if the infrared coagulation, cautery, or topical treatments may be helpful in addressing these HSIL. They also will be collecting specimens to try to understand if there's anything that we can do to help our HIV-infected patients further. This study is ongoing and open. It is available at Emory and GRADY, and Dr. Flowers is again the site PI for this study as well. And the enrollment is planning to enroll 5,000 patients nationwide. There is a minimum requirement of 5-year follow-up for these patients. And again, this study will hopefully help determine whether screening and treatment of HSIL should be the standard of care for HIV-infected patients or other groups with high risk of anal cancer. This is a study that we are opening or hoping to open soon here that is sponsored by the AIDS Malignancy Consortium. It's a small study, a comparison of patient-reported outcomes in HIV-infected and HIV-uninfected patients with anal cancer and understanding their barriers to diagnosis and treatment. So we hypothesize that HIV-infected patients would have a worse quality of life during treatment and face more barriers to either screening, diagnoses, and treatment compared to the HIV-uninfected patients. And we have two separate objectives and sort of parts to this study. The first one will be looking at quality of life outcomes for patients who are undergoing their cancer treatment. And then the second will be understanding those crucial social determinants of health that could be influencing patients' say, screening, diagnosis, and treatment and tolerability. So for part one, the quality of life section will be giving quality of life questionnaires before, during, and after definitive chemotherapy and radiation. And we'll also be looking at social determinants of health to see if there are changes in their health needs throughout that time period. Part two would be doing in-depth interviews with anal cancer survivors, so patients who have already completed their definitive treatment. And we'll be asking them to participate in these interviews where we will have a guide that asks them about key domains, so social ecologic framework to ascertain influences on individual behavior toward their cancer treatment. And this will be organized by individual, interpersonal, community, institutional, and policy level factors. We'll also be looking at our GRADY and Emory experience a little bit further and comparing the outcomes of anal cancer recurrence as well as survival among patients with and without HIV. And we have a retrospective study that's going to be looking at the survival outcomes as well as differences in clinical staging and treatment-related predictors of recurrence, as well as the effect of modern antiretroviral therapies on toxicities and compliance during chemotherapy and radiation for these patients. So in conclusion, the incidence of anal cancer is on the rise in general. HPV is associated with anal cancer, and this particularly has probably led to a higher incidence of anal cancer in the HIV-infected population, as well as in subpopulations with HIV-infected MSMs. We don't quite understand the tolerance of chemotherapy and radiation with HIV just yet. Seems like patients do appear to have worse toxicities or more severe toxicities if they have HIV. And we're not completely certain that the oncologic outcomes are as good as the HIV uninfected patients. It appears that long-term local control may be lower in HIV infected patients, despite possibly having same initial outcomes. Formal guidelines for screening for this cancer are needed as we saw in the first couple tables and graphs. This cancer is not going away anytime soon. We have few prospective studies that have permitted HIV-infected patients with anal cancer, and thus we don't really have generalizable treatment guidelines for HIV-infected patients. And we're particularly lacking in patients with low CD4 counts, and that consists of a good portion of patients with HIV who come in with a diagnosis of anal cancer. So inclusion of and attention to HIV-infected patients with anal cancer is urgently needed. And luckily for us, Emory and GRADY are uniquely positioned to address these challenges with diagnosing and treating HIV-infected patients with anal cancer. I'd like to thank you for your attention. I also would like to give special thanks to some of our supporters, including the AIDS Malignancy Consortium, EMCF, as well as Department of Radiation Oncology here, and our collaborators in the School of Nursing and Rollins School of Public Health. I'd like to also give a special shout out to some of my mentors, Dr. Flowers, Nguyen, Blake, and Dr. Torres. Thank you so much. I'd be happy to take any questions.
Thank you so much, Dr. Lin. That was a very comprehensive overview of anal cancer management, and you really did justice to the topic. To the audience, if you have any questions, please do not hesitate to use the Q&A feature located at the bottom of your screen. And while we wait on questions, let me just mention that next week, we'll be hearing from Dr. John Strickler from Duke University, who will be presenting overcoming resistance to targeted therapies in patients with metastatic colorectal cancer. And to view all upcoming Winship Grand Round lectures, please visit the Grand Rounds page on the Winship Cancer Center website or the Winship calendar. I see a question from Dr. Lawson, thanking Dr. Lin for an excellent presentation. And then is asking if you're considering including Hispanics and Asians in racial breakdown, I think in most of the epidemiologic studies moving forward.
I think we would like to, because we know that anal cancer impacts multiple races and ethnicities. I think, unfortunately, a lot of the studies right now doesn't have that distinct breakdown yet in terms of Hispanics and Asians. I know from personal experience at GRADY, we have treated a variety of patients, and we hope that at least when we report our retrospective studies, we'll be able to at least give a little bit of insight, but we are limited in the numbers.
Thank you. Dr. El Osta is asking for any role for HPV vaccine at this point in this population.
That's a good question. I think it's still uncertain whether it is effective yet or not. Most of the patients that we're seeing right now were not in that time zone of when HPV vaccines were available. And I believe there might be studies that are going on now that are going to look at HPV vaccine in the HIV positive population, but we don't know if that will play out in anal cancer until several years from now.
I also wanted to ask about some of the really somber data that you presented regarding new HIV infections, especially in the South. It's really mind-boggling that the Southern region has more new HIV infections than practically all the other regions combined. But does anal cancer incidence follow the same regional distribution? And if it does, should we be thinking about focusing more efforts, for example, based on geographic trend?
That's a good question. I don't know if anyone has looked at that yet, but that's something I think that should be investigated if it hasn't. I think it may make sense that it follows a similar geographic distribution, that if we have more of the HIV diagnoses, then we may see more of that incidence. I just don't know if that has been done yet.
Thank you. There's another question referencing a lot of work that's been done in pathology, showing that mucosal injury leads to different HIV mutant transmission. And Dr. Keller is asking that this may presumably be a problem in men who have sex with men.
Mm-hmm.
He's asking if you're looking at different HIV mutations in this special population.
I don't think we have yet, at least my group hasn't, but that's certainly something that we'd be open to looking into. And I would love to learn more about that.
Thank you. I don't know if there are going to be any other question, but it's been a phenomenal talk. Thank you very much once again. And we hope to see the audience participate next week. Thank you all.
Thank you.